Chapter 15, Part A, Trauma, Mobile, and Surgical Radiography. Please view all 65 slides. There is some review questions that are in the middle of the PowerPoint. That is not the end of your learning, so please look at all slides. Mobile and trauma radiography. On the left, you have a mobile portable procedure. This appears to be the wrist that they are imaging. And on the right, you have a trauma patient on a stretcher, and they're doing a chest x-ray with a portable machine. You can do everything portable that you can do in the actual room. The images aren't near as nice as what you would see in the room, but it is doable. Terminology. Terminology in trauma is very important, as not everything is the same. It might look similar, but it is not. On this slide, you have dislocation or luxation, displacement of bone from a joint. In this image, it is a shoulder dislocation. On this side, you have the subluxation, a partial dislocation of the joint. Subluxation of C-spine, C5 vertebra displaced posteriorly, but it's not a complete dislocation, so they call it a luxation. Sprain, forced wrenching or twisting of a joint resulting in a partial rupture or tearing of supporting ligaments. A fracture, a break in a bone. A contusion is a fancy word for bruise type injury without a fracture or break in the skin. Fracture alignment terminology. Apposition, relationship of the long axis of fracture fragments. Types of apposition. One is an anatomical apposition. 2 is a lack of apposition. 3 is a buoyant apposition. Angulation, loss of alignment. There are 3 types of angulation. You have the apex angulation, which describes the direction or angle of apex of the fracture. Number 2 would be a varus angulation, which is an angulation towards the midline of the body. Number 3 is the valgus angulation, which is an angulation away from the midline of the body. Types of fractures, which is something that we have gone over. This is pretty much a review on this slide. You have your simple fracture, where the bone does not break through the skin. It's a closed fracture. You have your compound fracture, where bone protrudes through the skin, or it's also called an open fracture. You have your incomplete fracture, where the fracture does not traverse through the entire bone. Examples would be a torus fracture, a green stick fracture, a plastic fracture. On the images on the right, you have an image of your compound fracture, as well as an incomplete fracture. Other fractures, you have complete fractures, which is 2 pieces. You have the transverse fracture, oblique fracture, and spiral fractures would be what your complete fractures would be, and you see that in the image on the left side there. Your comminuted fractures, 2 or more fragments. Segmental fracture, which is a double type fracture. Butterfly fracture, which is 2 fragments, or splintered fracture, which is thin, sharp fragments. And you see a comminuted fracture on the right image. You also have an impacted fracture, one fragment driven into another. Ends of bones is normally where you will see that, such as the radius that you see here on the right-hand side of your screen. This one is actually a very common one, especially amongst elderly. You also have your named fractures, the Colles fractures, posterior displacement of distal radius, or your Smith fracture, which is the reverse of the Colles fracture with anterior displacement. The image to the right is a Colles fracture. Montague's fracture is the proximal ulna along with dislocation of the radial head. You also have a Pott's fracture, ankle fracture of distal fibula with frequent fracture of the medial malleolus. You'll see on the images on the right, the top is a Montague's fracture and the bottom is the Pott's fracture. Additional fracture types, a compression fracture. Here is a vertebral body collapses or is crushed. And then on your next slide, you'll have the stellate fracture. Fracture lines radiate from a center point of injury. You have your tuft fracture, comminuted fracture of the distal phalanx. Trauma adaptation positioning, principle 1. Two projections, 90 degrees from each other, often with no patient movement. Requires adaptation of CR angle and IR placement. This is where your critical thinking skills come into play, because you need to figure out how to get the images 90 degrees from each other. Seems simple, but it's not as simple as you might think. Principle 1 exceptions. Barriers to true AP and lateral, like splints, traction bars, etc. Exceptions are to true CR to part to IR alignment. Trauma oblique C-spine exception, IR is not perpendicular. Horizontal beam projections. You need to remember that there's divergency of the X-ray beam, and you need to ensure that the body part is not projected off the IR. Trauma and mobile radiographic positioning. On this slide, you have the AP chest. On the left, you have AP supine patient that obviously cannot sit up, probably due to a trauma. On the right-hand side, you have AP semi-erect. This patient was able to sit up slightly, but not completely, possibly due to trauma. Not all patients have to be done supine or semi-erect when doing them portable. Some of them can actually sit up straight for you. So lateral decubed chest. This is usually done for air fluid levels. You have a radiolucent pads under the shoulders and the hips, which you actually don't see here. This looks like it's just done on a cart. And then you want to make sure you have the arms above the head. This isn't actually done portably. This is probably a trauma patient that they brought into the room to be done. This is a portable AP abdomen. still want to center your CR at the iliac crest, and make sure that you get kidney to bladder. This is a left lateral decubitus abdomen. You're going to make sure you have support board or sufficient pads underneath the patient. The CR is 1 to 2 inches above the iliac crest. This is your dorsal decubitus lateral projection. Useful projection to rule out possible abdominal aortic aneurysms. PA and lateral forearm for trauma. Patient will be laying on their back. Probably will not be able to rotate their arm due to pain or whatever is going on inside. So you'll do your PA forearm with them laying like shown on the left image. Then you'll elevate the arm in the right image with bolsters or foam pads and place the IR behind it and move your C-arm to a horizontal beam. AP hand and or fingers. On the left you have your AP proximal metacarpals and wrist. Most of your patients will not be able to rotate their extremities or lay them flat, so you generally end up having to prop them to help with pain, and also to get images you may have to angle your CR. On the left you'll notice that the CR is angled just ever so slightly to visualize the wrist. On the right you see that they have not only built up the IR in order to get a decent AP of the mid and distal phalanges. And they also put a slight angle on the C-arm in order to flatten out those fingers for the patient. This is the AP oblique and lateral hand and wrist. These all look great, but they are not, they are textbooks is what they are. This may not be what happens when you get out into clinic, and you will have to adjust to whatever you can do as to what the patient can do. PA and lateral thumb. For trauma patients, you definitely want to make sure you're using a sponge in order to hold them still in the position that you need them to be in. PA and lateral elbow. PA elbow, the CR is parallel to the inner epicondylar plane. You can see in the image on the left that they have elevated the elbow so that there is no foreshortening of either part of the forearm or the humerus. On the lateral elbow on the right, the CR is perpendicular to the inner epicondylar plane. You'll notice that the CR is actually angled for this patient since the patient cannot position appropriately. Trauma axiolateral projections of the elbow. On the left is a projection for the radial head. The CR is angled 45 degrees towards the shoulder. On the right, the projection is for a coronoid process. CR angle is 45 degrees away from the shoulder. AP and lateral humerus for trauma. For the AP, the CR is perpendicular to the epicondyles. Make sure you include both joints. For the lateral, the CR is parallel to the epicondyles. You'll notice an image on the right that you're only getting the distal end of the humerus. In order to get the proximal end of the humerus, you would have to do a transthoracic shoot through. Transthoracic lateral. Horizontal CR is centered to the surgical neck and the center line of the grid. AP trauma shoulder. CR is perpendicular to the shoulder joint. No rotation in the arm is done in a neutral position. Lateral scapular Y. With a sponge, you're going to roll your patient up about 45 degrees, give or take. The CR cross-angled if required, and grid is also crosswise. AP and lateral knee. For the AP knee, there is no CR angle for an average patient. On the lateral knee, the CR is horizontal and parallel to the epicondyles. AP foot. You can elevate the patient's leg underneath some sponges and also prop up the IR in order to match the foot's angle. The CR would still enter in at the same place that you would for a normal AP foot. If you match the angle of the CR to the cassette and then decrease the angle by 10 degrees, you should have a perfectly positioned foot for trauma. Oblique foot, optional for trauma. The CR is angled 30 to 40 degrees lateral medial. Lateral foot. Using a horizontal beam, the CR will enter laterally instead of medially for the lateral. For an ankle, AP ankle, CR midway between the malleoli. CR is perpendicular to the long axis of the foot. For an AP mortise, the CR angle would be 15 to 20 degrees lateral medial. For the lateral, the CR is lateral to the malleolus, entering in the lateral side. AP and lateral lower leg include both joints. CR is parallel to the long axis of the foot. Medial oblique knee, optional trauma knee projection. The CR is angled 45 degrees lateral medially. IR is perpendicular to the CR. AP and lateral mid-distal femur. Grid lines should be vertical for CR centering. AP pelvis and hip. AP pelvis, the initial projection. Top of the cassette 1 inch above the crest. CR perpendicular to the center of the IR. For an AP hip, CR is perpendicular to the hip. Rotate the leg 15 degrees internally if hip fracture is ruled out. Inferior superior axial hip, the Denalius Miller method, also called the shoot-through hip. Horizontal CR perpendicular to the femoral neck. Horizontal beam lateral C-spine. Horizontal CR to C4 and center line of grid. No head or neck manipulation. Swimmer's lateral for the C-spine. Horizontal CR centered at C7 to T1. You're going to raise up the right arm to get that shoulder out of the way. Lateral T-spine, horizontal beam, CR to T7. Lateral lumbar spine, horizontal beam, CR is level of L3, L4. Trauma lateral skull, CR is 2 inches superior to the EAM. No tilt or rotation, no suspected C-spine injury, and without head manipulation. Trauma AP skull projections. AP 0 degree, CR parallel to the OML, and CR centered to the glabella. AP reverse Codwell, CR is 15 degrees cephalad to the OML, and CR enters into the nasion. Trauma AP axial projection. CR is 30 degrees cauda to the OML, and it enters in at the level of the EAMs. Lateral facial bones. CR is centered midway between the outer canthus and the EAM. AP reverse waters, the acanthoparietal. CR is parallel to the MML, and it enters in the acanthon. Image evaluation, peaches ridges just below the maxillary sinuses. Modified AP waters. CR is parallel to the LML, still enters the acanthon. Image evaluation, the peaches ridges in mid-aspect of the maxillary sinuses. Best demonstrated is the floor of the orbits and entire orbital rims.